Good day, I'm Jeanin van Hooft, consultant gastroenterologist at the Academic Medical Center in Amsterdam, the Netherlands, where I'm the lead of the HPB clinical research group. Pancreatic disease is one of our main focus points. As part of this, we run a dedicated pancreatic cyst outpatient clinic together with our surgeons and radiologists. One of the issues we have encountered in this setting was the disparity between the currently available guidelines regarding the treatment of pancreatic cysts. The observed differences initiated our research into this particular theme, which is outlined in the article, comparing 3 guidelines on the management of surgically removed pancreatic cysts with regard to pathological outcome. We would like to thank Gastrointestinal Endoscopy for inviting us to discuss our paper here in more detail. As you all know, pancreatic cysts are increasingly identified using cross-sectional imaging. The primary goal of the patient management presenting with premalignant pancreatic cyst is the alleviation of symptoms and prevention of malignancy, while avoiding unnecessary surgery. Although dysplasia does not always progress to malignancy, surgical resection of pancreatic cyst with high-grade dysplasia is generally accepted. In most of the patients with suspected premalignant cysts, surveillance is suggested, though there are indications for surgical resection based on symptoms or the perceived risk of malignancy. There are currently three main guidelines available: the guidelines of the International Association of Pancreatology, the European Study Group on Cystic Tumors of the Pancreas, and the American Gastroenterological Association. Although these guidelines overlap partially, they vary in their advice for surgical resection in patients with intrapapillary mucinous neoplasms, IPMNs. The main difference is that whereas the European and the IAP advise resection in patients with IPMN with main duct involvement, the ESGE recommends to perform resection only if there is main duct involvement with a nodule or in case of cytological suspicion of malignancy. It was due to these contrasting recommendations we decided to perform this study, where we aim to compare the final pathologic outcome of surgical removed pancreatic cyst with an indication for resection according to the 3 different guidelines. We extracted all patients who underwent pancreatic resection from a prospective pancreatic cyst database. The final histopathological diagnosis was compared with the initial indication for surgery stated by the guidelines of the International Association of Pancreatology or the European Study Group on Cystic Tumors of the Pancreas and the American Gastroenterological Association. We considered surgery in retrospect justified for malignancy, high-grade dysplasia, solid pseudopapillary neoplasm, neuroendocrine tumors, or symptom improvement. Furthermore, we evaluated the patients with suspected intraductal papillary mucinous neoplasms separately. In total, 150 patients underwent pancreatic cyst resection. In retrospect, surgery was justified in 45% of patients according to the aforementioned criteria. In patients with suspected IPMN, 75 in total, most would have had a resection according to the IIP or European guidelines, respectively 89.3% and 90.7%. And overtreatment would have been common, 41.3% and 42.7%. The EGE guideline would have avoided resection in 21 patients, in contrary to retrospectively 11% and 9% when the IAP or European guidelines would have been applied. Nevertheless, 4 of 33 patients with high-grade dysplasia or malignancy would have been missed with the EG guidelines, compared with none when the IAP or European guidelines would have been applied. To summarize, although fewer patients undergo unnecessary surgery based on the EG guideline, the risk of missing malignancy or high-grade dysplasia with this guideline seems to be considerably high. It is important to note that the study is limited by the fact that only patients who underwent resection were considered. Therefore, the number of patients undergoing surveillance where resection is actually warranted due to high-grade dysplasia is unknown. Unfortunately, this bias is inevitable, as definitive diagnosis and grade of dysplasia can only be reliably determined through histopathological analysis. The number of false negative preoperative diagnoses of innocent cysts is therefore unknown and could not be compared between the current guidelines. Furthermore, we cannot predict if the cyst without malignancy, which we resected, would have progressed if they had not been resected. Especially in patients with low-grade and borderline dysplasia, it is unknown whether, and if so when, these patients would progress. As progression rate seems the highest in IPMN with main duct involvement, resection of low-grade or borderline dysplasic cyst might already considered to be necessary, especially in younger patients. So up to now, it remains challenging to determine the necessity and, if necessary, the optimal timing of surgery of pancreatic neoplastic cysts. However, the EEG guidelines does not seem to be the safest choice of the current available guidelines.